Hello, everyone, and welcome to another exciting year of the Human in Sports Performance Series, hosted by the Swag Initiative and myself, Anthony Smalls. This first session that we're kicking off with will be Dr. Robert Parisian, who is an orthopedic sports medicine surgeon. He's done great work all over the country, especially with Team USA. So I hope you're ready and interested to see the great work he's been doing. Take it away.
All right, so it's an honor to be here with the Swag Initiative. Thanks again for the invitation, Anthony. So again, my name is Robert Parisian, and I am a orthopedic sports medicine surgeon here at the Icahn School of Medicine at Mount Sinai. I provide team and event coverage for the U.S. Open Tennis Championships here in New York City, as well as for the U.S. Ski and Snowboard team, USA Fencing, and finish line coverage for the NYC Marathon. And again, it really is a pleasure to be here and to be talking with student athletes that do have academic goals, because we'll get into that's exactly what I was when I was going through my process as a young student athlete and trying to figure out what my next phases of my life were going to be. And I'm also involved, and we'll get into with an organization that works with that. So I just wanted to discuss orthopedic sports medicine and then really get into the pursuit of that. So what does it mean to go down a path of medicine, and specifically orthopedic sports medicine? And then what does the practice of that look like? And I figured I'd share some interesting cases and case examples to sort of get you all interested potentially in this career path. So my disclosures are here. I'm a member of the Council of Delegates for the American Orthopaedic Society for Sports Medicine. I'm also an associate editor for the Journal of Cartilage and Joint Preservation. I'm on the editorial board of 3 of our major journals. I'm on the research committees for our Sports Medicine Society and our Arthroscopy Society, as well as the Learning Center for our Arthroscopy Society. Media committee for Society of Orthopedic Surgeons, as well as the Board of Trustees for Athlete Soul and the Advisory Board for Concussion Legacy Foundation. And Athlete Soul, I think, fits in well with this, because again, as a board member there, what we focus on is really transitioning, and when athletes transition to life after sport and all of the challenges that are there. So I think this is a wonderful thing that exists to have the Swag Initiative to help all the young student athletes sort of get the ball rolling to start think about this this process and this transition is what they might want to be pursuing and doing with their post-athletic careers. So SWAG, I love the acronym as an athlete and now as a orthopedic sports medicine surgeon. So scholar athletes with academic goals. And I really love this because for many reasons, but also scholar comes first. And I think that we have to always remember that. And I think that for all of the young student athletes that are going to be listening to this discussion, to this talk, I think that you're already a step ahead by being a part of this. And so scholar certainly comes first. Our athletic careers then come secondary to that. And then I think having the academic goals is wonderful, and it's just a matter of how to guide that. So we'll get into that a bit here. So I went into the definition of swag. Cambridge Dictionary says it's a confident appearance or way of being. The Oxford Dictionary calls it a confident attitude that you admire. And I would also like to add to that when thinking about athletics, and then also thinking about being successful in life after sport. And we're talking about orthopedic sports medicine today, but I would even extend that to the STEM, right? The science, technology, engineering, and math aspects of post-athletic life. I think you need to have vision. Vision is the ability to think about or plan the future with imagination or wisdom. So I think it's very important to have vision throughout this process. You need to be passionate, and you need to find that passion. And again, that's defined as a strong feeling or emotion. And I would also say passion with a purpose too. So you want to have something that you're moving towards, and that obviously plays into vision. I think perseverance is very important. That is the continued effort to do or achieve something despite difficulties, failure, or opposition. And perseverance will get you in a long way in life, as it did in athletics. And then attitude. I think moving forward with a positive attitude in life is only going to help you in a positive way. Again, before every game, my father used to ask me, what do you bring with you? And the answer always was attitude. And I think that I bring that to every aspect of my professional life as well. So I think that's very important. So discussing these different things, vision, perseverance, attitude, swag, I think that this gentleman here, Michael Jordan, you look at him at his days at North Carolina, you look at him as a Chicago Bull. He certainly had what I would say is swag as an athlete, but he also had that vision. You better believe you asked young Michael Jordan as a North Carolina basketball player, where were you going to end up, and what were your goals, and how did you foresee yourself in the future? He would most likely said an NBA championship and most valuable player awards. And so, and his goal was to be the greatest basketball player there was. So he had that vision. This is you recognize the Williams sisters here. Same thing, when they were young, they definitely had that vision. They had perseverance. They had the right attitude when they approached things to their successes in life. And so they didn't just have a passion. They had a passion with that purpose. This individual too, Tom Brady, very similar. And during his Michigan days, and even when he got drafted later in the later rounds of the draft, Tom Brady absolutely had his eye on the prize and knew where he was going and knew where he wanted to end up. And this gentleman here, I don't know if you recognize him, but this is on the left. There would be a young Lewis Hamilton. And then on the right, Lewis Hamilton today, he's one of the most successful F1 drivers. And so same thing with him. I think these are great examples of individuals who had swag when they were young, and they had a vision and a passion with a purpose. Now, we all know Tiger Woods. Well, Tiger Woods had all this as well. However, I want to add that you also need some guidance, right? Here's Tiger with his father, and Tiger had some fantastic guidance along the way. And he had some help, and we all need a bit of help. We all need some mentorship. And that leads into this with Jack Nicklaus and Tiger here. And this has been a great sort of mentee mentorship role. So Jack has been a great mentor for Tiger over the years that has really helped him, and also was Tiger had something to shoot for and someone that he wanted to be like and then surpass. And so I think these are also very important things. So having the appropriate guidance and having the appropriate mentorship during the process, which again is why I think this swag initiative is so valuable for young student athletes. So my goal this evening, yes, to convince all of you to become orthopedic sports medicine surgeons, all of the young student athletes that are going to be listening to this and watching and tuning in. How am I going to do that? Well, first I want to educate you on the pursuit of this path and to be an orthopedic sports medicine surgeon, and then educate you on the practice and sort of share some interesting cases and get you involved a bit and grab your interest. So the pursuit. This is Brown University. This is my path. So I went to Brown University as an undergraduate. And so, you're going to go to a four-year university, get your undergraduate degree. I majored in economics at Brown University. And while I was there, yes, I was also a young student athlete. So I played football during my time there. So I was exactly in the place that you all are in right now as part of the SWAG initiative, as young student athletes, scholar athletes, with academic goals, trying to figure out their next path in life. And so I can certainly relate to you. We were fortunate enough to win an Ivy League championship during my time there in 1999. And then when I went on for my medical pursuits, I actually was an economics major at Brown. So I had to go back and get my pre-medical prerequisites. And I did this at NYU. And I went to NYU to do that, a post-baccalaureate program. And I did all my science-based courses because you need to have a prerequisite. So if you don't major in pre-medical studies in undergrad, you need to go ahead and you need to get your prerequisites for medical school. And each medical school differs slightly, and that's something you can investigate once you get closer to that. But I did mine at NYU. While you're going through this process to get into medical school, you have to take the MCAT examination. This is the Medical College Admissions Test. It is a rigorous test, and it's scored. And each university looks at the score. They're going to look at other things as well, but this is part of the process. You have to take the MCAT. And again, I'm trying to lay out before we get into the practice of orthopedics is how do you get there? Because for me and many others, that path wasn't always so clear. We had to figure out a lot of this on our own. And so just having a concept and an idea of what that path looks like ahead and how to take the next steps in your process I think can be very valuable and very helpful. So then once I took the MCAT, I then went to Tufts University School of Medicine. And again, once you take the MCAT, that's your admission to medical school. Then you go to medical school, and medical school is 4 years. Every medical school is going to be 4 years. No matter what you go into after medical school, you're going to have that 4-year training. The first 2 years is going to be in the classroom typically. And again, some medical schools have shifted and adjusted a bit, but it'll be in the classroom. The second 2 years of your 4 years of medical school, will be clinicals, where you're going to get in the hospital, you're going to be treating patients and seeing patients. And this is a very important aspect of your medical career, because this is where you are learning to become a doctor. You are not a doctor yet. You are a medical student, and when you graduate medical student in 4 years, right before you start your residency, then you become a doctor, and you enter your residency as a physician, as a doctor. While you're in medical school, you take something called the United States Medical Licensing Examination Step 1. There's 3 steps of this. You take the first one while you're in medical school, and then you also take the second one, which consists of a clinical knowledge data test, which is an entire 1-day test. So the step 1 is a full day test, 8 to 9 hours long, and the same thing with this one is a full day test as well. And these are going to be important tests for you when you're trying to enter residency. And then residency is you either deciding that you want to go into orthopedic medicine, which is what I'm here to convince you to do today, or whether you want to go into pediatrics or internal medicine, or some other type of medical field, neurosurgery, cardiology, for example. But this is the way that the process works. You take step 1, then you take step 2. These are written examinations, and then you take another one that is a clinical skills test of step 2. And this is all while you're in medical school and you're moving through your path of medical school. And this one really works on clinical examination skills, everything which you'll be directed to while you're there. But again, just laying the groundwork and the path that lies ahead, and the path of pursuing an orthopedic sports medicine career. But this really, again, is for all careers. And I want to say, during all that, it's 4 years of hard work. It's all those examinations that you're studying for, yes, and it is challenging, but it's also a lot of fun as well. And why do I put these pictures up here? Well, I put these up here to demonstrate the lifelong friendships and relationships that I built over that time, and you will build. So when you're in high school, you have your very close friends that you build friendships with, and that's your group that you're close with, and that you share things with, and that you learn things with. Then you move on to college and you have another very close-knit group of friends that you form. I would say medical school is going to be the same way. It'll be slightly different because you're a bit older, but while you're going through this, I put this up here because for me, as a young student athlete, this was a great way to recreate that locker room, recreate that sense of camaraderie, where we were all studying together along that path. And don't get me wrong, my medical school class is a lot larger than this, but this is my very good core group of friends that I made that are going to be lifelong friends moving forward. So bear that in mind, that you're going to be having these great relationships and these great friendships, and it's really going to, in many ways, recreate that camaraderie that you have as a young student athlete as you go through this. So then, following medical school, you go into residency. And so I went into an orthopedic surgery residency, and I did that at Boston University. These are my co-residents that I went into that residency with. And again, this is another good core group of guys in this instance, but it could be male, female. But this is a good core group that are going to be lifelong friends of mine that I did a 5-year residency with. So for orthopedic surgery, the residency is 5 years. So again, 4 years of medical school, then you go into residency. And for orthopedic surgery, it's 5 years. For anesthesia, it's 4 years. It differs for whatever residency you decide to go into, whatever subspecialty. But if it's orthopedic surgery, every residency is 5 years. And they're all different size. Mine was 5 here at Mount Sinai, where I practice and work. We have 7 residents per year. And again, as you can see, and why I'm putting up these photos and discussing this, is to show that you do have a group of your teammates that you're doing this with. And so there's 5 residents per year at Boston University, 35 residents total over that time span. Or rather, no, 25 residents during that time span. But you have, during that time of residency, you're doing USMLE Step 3 as part of your additional licensing examination, and you do that during your residency time. And so remember that you take 2 during medical school, you take another one during residency. And these are all your licensing examinations. Now, during residency, what are you going to do? You're going to do things like this. You're going to be in the emergency department examining patients as an orthopedic resident. You're going to be in the trauma bay. This is the trauma bay. We had a patient that came in that was experienced trauma. We're getting x-rays of that patient. So we're getting called to the trauma bay. You put on the lead and you're positioning the patient, you're getting these x-rays, and then you're calling the team and discussing with the team what the next steps forward are. And so see, these are part of the things that you're going to be doing as an orthopedic surgery resident. This is a patient here that we were seeing in the emergency department, and I was teaching my junior resident at the time how to place what we call a traction pin. But basically, it's a pin that you drill through the proximal shin or proximal tibia because they had a fracture that was higher up in the hip, in the upper leg region, in the femur. And so these are just different things and different things that you're going to do. As I said, that for me as an athlete, when you're a senior and you're teaching, the junior, the sophomore, the freshman, it doesn't change when you go up and you move through a residency, for example, and this being an orthopedic surgical residency where I'm holding the leg for my junior resident and teaching him how to go through this process and doing this. So you have that camaraderie, you have that ability to teach, and you have your teammates that you're working with. And so here's an example of us doing that in the emergency department. And then you do other things like this. You go to a lab, this is in Chicago. It's a cadaveric lab. We were there learning on cadavers, how to do arthroscopic surgery. And you can't tell in this photo, but there are, probably 100 other residents and fellows that are there at this lab right now, working on cadavers and just honing our skills and improving our skills. And then, as you can see here, it was during the fall, so we had some of the games on at the same time because this being a sports medicine lab. Everybody was interested in athletics, and so you're doing both at the same time there. But again, it's a lot of hard work. It's a long path, as it should be long, and it should be challenging because of what we get to do at the end. The path itself is quite enjoyable once you get on it. And then, as I said before, guidance and mentorship is vital no matter what you're doing in life. Because you're never going to do it alone. You're going to need that guidance. You're going to need that mentorship. This is one of my close friends now, who is still a mentor of mine, but certainly during my training, I trained under as both a resident and during one of my fellowships. And so I did my fellowship at Boston University Medical Center after my residency, and I was able to train under him again. His name is Dr. Tiger Lee, and he's one of the leading members in our sports community. And then here's when we graduated residency, the same group of guys. And now, aside from that first photo, we are now very tight. We are very close friends. We went through a lot together and accomplished a lot together. It's a very good group that are going to be lifelong friends of mine. And so, again, forming very valuable friendships and be through these different environments that you go through, whether it be undergrad, medical school, residency, very, very enriching and fulfilling environments and friendships that you will take through in life and carry through in your life. Now, when you're finishing residency, for orthopedics, you take a board examination. This is your orthopedic boards. And this is a test that you take as you're going from residency into your fellowship, as your orthopedic board examination. And then you go into fellowship. And what is fellowship? Well, fellowship, you decide what kind of orthopedic surgeon do you want to be? Do you want to be a hand surgeon? Do you want to be a spine surgeon? Do you want to be a sports surgeon? Do you want to be a joint replacement surgeon? There's all different aspects of orthopedics. I obviously chose sports medicine, which I hope you choose when you go down your path. But anything obviously is very fulfilling. So I did mine at Boston University. While I was there, I was able to be a team physician for Boston University athletics. And I think this is one of the wonderful things about being a sports medicine surgeon is that you get to work with teams. You continue to work in around athletes. And so Boston University hockey team I worked with, which is a fantastic hockey team. I did a second fellowship at the University of Pennsylvania. This is the campus at Penn in Philadelphia. And during that fellowship, again, it was sports medicine. I did a lot of cartilage restoration work during that fellowship. And I was able to be a team physician for Penn athletics, all of the athletic programs that we covered every single football game. And that was great for me because I had played, I said, at Brown University, and now I was able to come back and be a team doc for the Penn athletes and for Penn football. And that was a great experience. And you're working with the trainers for both the football team and all the other sports. And again, continuing to work with athletes, working with non-operative sports surgeons, working with other orthopedic surgeons. And so you always have this team environment around you. So the camaraderie is there when you are pursuing a path in orthopedic sports medicine, for example. After this, and so during this fellowship, you can see some of the relationships that I made. So these are co-fellows of mine. Some of these are residents that I taught during different labs, teaching arthroscopic skills. And again, there's always this sort of teaching process that's happening in this teamwork that's happening around all of your training processes. So again, very enjoyable, and it very much can recreate that athletic environment, especially if you came from team sports. And now, again, back to mentorship. This gentleman is Dr. Kelly, John Kelly. He is one of the most esteemed shoulder and sports surgeons in the country. He was someone that I trained under, and again, now is a very close friend, and still is still my mentor to this day, and forever will be, and has been very valuable and instrumental in my career moving forward as a sports medicine surgeon. And so again, these are your coaches. Your mentors are your coaches moving forward in life, and orthopedic sports medicine is littered with mentors. As long as you seek them out, you know, they are there, and that is very much a part of this process and a part of this career path. After that fellowship, I did a final fellowship at Harvard Medical School in hip preservation surgery, which is sports hip. And so now I do sports surgery of the shoulder, elbow, knee, and also I do sports surgery of the hip, and I did that at Harvard Medical School. So here's the path. Here was my path. Undergraduate, 4 years. I did that at Brown University. I went back and did a post-baccalaureate pre-medical program for 2 years. Not everybody has to do that. If you do pre-medical studies as an undergrad during your 4 years, you don't have to go and do this post-baccalaureate pre-medical studies program. So you can cut out those 2 years. I didn't. I was an economics major, so I went and I had to do this pre-health program to get my prerequisites for medical school. Then medical school is 4 years. Then orthopedic surgical residency, no matter where you go, if you go to orthopedic residency, it's going to be 5 years long. Fellowships each are 1 year. I did 3, but the vast majority of people only do 1. And so my path is about 18 years, including undergrad. The other path would be about 14 years. If you only do 1 fellowship instead of 3, and you cut out that post-baccalaureate training, you can get this done in 14 years. And as I showed you, very great mentors during this path, very great friendships and different sort of teams that you work with during that path as an undergrad, in medical school, in residency, and throughout your various fellowships that you may or may not do. You're going to have lifelong friends and throughout the process, which I have had, and very, very fulfilling. So I know it's long, as it should be long, and it should be challenging, but it's also very enjoyable. So now getting into practice. So this is this is Central Park. If you look down to the left, that tall black building right there on Central Park, on the bottom left, that is Mount Sinai Hospital. That's where I am right now in my office, a street over from there. But this is Central Park, and it's a beautiful location. This is where I now practice. And so during practice now, I get to be a team physician and provide event coverage for the US Open. So this is the US Open here in New York City. It's going to be happening and coming up at the end of August and beginning of September. And so I'm providing coverage, sports medicine coverage for this event, which is, as you can imagine, very enjoyable to do as a sports medicine surgeon. I also provide coverage for the US ski and snowboard team. In addition to that, I am a team physician for USA fencing, and I provide finish line coverage for the NYC Marathon, all of which are incredible things that I appreciate as a former athlete and someone who just loves athletics and loves to be around athletics. Now I get to take care of these athletes and make sure that they're healthy and help them sort of stay away from injury, and then help them get back to their athletic competition if they, unfortunately sustain some sort of injury. So moving forward, now we get from the pursuit of an orthopedic sports medicine career, we get into the practice of orthopedic sports medicine. And without getting down into too much of the details with regards to different things that we do on a day-to-day basis, I thought I would just kind of run through some case-based scenarios to give you a flavor and give you a taste of some of the things that we do as orthopedic sports medicine surgeons, and really to get you interested as a young student athlete that may be considering a career in orthopedic sports medicine. So the first one I'd like to discuss is a 29-year-old right-hand dominant female, a history of right shoulder instability. So that means she had dislocations, or shoulder dislocated from trauma. She had a prior stabilization surgery, which means that she had a minimally invasive surgery to fix the labrum in the shoulder, which was contributing to her instability, which was her injury. And so then when she came to me, she had still instability of the shoulder. She was 29 years old, still very, very active, and was a weightlifter. And she has a Bankart lesion, which is a labral tear, and a Hill-Sachs lesion, which I'll show you. And so the plan was we got to go in with an arthroscopic surgery to address this. And so this is her x-rays. This isn't her exact x-rays, it's somebody else, but it basically gives you a sense. But at the bottom here, I don't know if you can see my cursor, but at the bottom here is a bony fragment of the glenoid. So this is the socket. This is the ball of the arm of the shoulder, and this is the arm itself. So the shoulder is a ball and socket joint. This is your clavicle that comes out here, and these are your ribs right in through here, and your lungs are this black area behind the ribs. And we're really looking right here in the socket aspect. This little fracture right there. I look on a different view, you can see there, this is a little fracture right here. This is the scapula looking from the side. Again, these are the ribs right here. And then I look from a top-down view, it gives us another view. This is the socket here. This is the ball of the arm, and here's the arm right here, and this is the whole shoulder joint right there. And then this is an MRI. So an MRI allows us to see the soft tissue structures of the shoulder. Again, this is the ball of the shoulder here, the head of the shoulder, humeral head we call it, and this is the socket on this side. And if we scroll through, it gives us different images here, and then we can see down here we have some disruption of the socket right here, and this is contributing to instability. This is the rotator cuff that comes over here and connects to the humeral head right here. The rotator cuff is fine, it's in good condition. Really, her issue is down here, what we call the anterior inferior aspect of the glenoid or the socket. This next image is a CT scan. The CT scan really allows us to look at bone and osseous anatomy, but it gives us a very detailed description of this. And so this one I'm looking straight on, we are looking straight on at the socket, which is called the glenoid. We've subtracted the arm away so we can look just directly onto the socket, onto the glenoid. And as I scroll through, you can appreciate, hopefully here, you have this little fragment down here, and that's a little bony defect and a bony fragment because of the shoulder dislocation that she's been experiencing. Now this is a 3D reconstruction. You probably appreciate this even more. Again, the arm has been subtracted out of this imaging, so we could only look directly at the socket and at the shoulder, the glenoid, which is, it's in a way, if you can think of it, it's like a ball on a tee. For a golfing analogy, if you have a ball that sits on a tee, the ball is going to be the humeral head, the tee is going to be the socket, and it sits on the socket. And you can see here, you have this bony fragment in the front right here that is damaged because of the shoulder dislocation that the patient has experienced, or multiple shoulder dislocations. So now, as I said, the plan is do an arthroscopic procedure. What is that? That means you stick a camera into the shoulder through small, like 1 centimeter incisions. And it's really a minimally invasive approach to any joint, but in this case, the shoulder. And then you fill that joint up with fluid, and you go in and you address whatever is wrong with the shoulder, whatever pathology you find. And so this here is me looking in from the back of the shoulder. And on the right side is the humeral head here. On the left side, we have the socket of the glenoid. This is actually the biceps tendon that's coming up inside here, and it's connecting to part of the labrum that's up here. And then this, again, this is the socket, and we're going to take you through a tour of the shoulder right now. The humeral head is on the right, the socket's on the left. The labrum is up top. Now we're looking at the humeral head, the ball of the shoulder. We're coming all the way around. Here is the damage of the Hill-Sachs lesion. This happens when the shoulder dislocates and re-engages. You get that lesion over there in the back. It's not very big, but that's called the Hill-Sachs. And then here's the superior, the top part of the labrum. Way above us is the rotator cuff. Directly forward is the biceps. And then now we're coming on and we're looking, and all this should be labrum, and all this is no labrum there. It's all gone. It's all off the side of the glenoid and off the side of the socket. So the labrum is completely torn off of where it normally anatomically should be located. And so our job is to go in, grab this tissue, bring it back, and recreate the labrum so the patient doesn't have any more instability of that joint. Again, here, this is the socket side here. Here's all that tissue that has been peeled off of the labrum because of her injuries. And this is why she's having some instability of the shoulder. Same view here, looking right down the side of the socket, of the socket of the glenoid here, right here. And all this tissue is peeled off. And so now this has really been scarred down. So we need to go in and we need to peel that off a little bit. This is a chondral defect or articular cartilage. This is the cartilage here. It's a big cartilage defect that they had. The patient had because of the trauma of all the dislocations. This is me with my probe inside the shoulder, peeling up the labrum, showing that the top of the labrum, the superior part of the labrum, actually is intact. You can see right here, it's still intact. So that's not a problem. So we don't go ahead and fix that. We just want to focus way over here on the anterior aspect of the glenoid. So this big cartilage piece we had to take out because it was a flap and it was all loose cartilage. So we removed that cartilage there because that was symptomatic likely for the patient. This is me coming in with an elevator, elevating all that tissue off so I can get good tissue to bring up and to provide some stability to the shoulder. This right here, if you can appreciate, this is my instrument coming in. This is a big bony fragment right here, a big piece of bone that belongs up towards the glenoid, up towards the socket to provide increased surface area. And so we'll have to bring that up as well. And then again, here's the elevator, my instrument that's coming in here, peeling off this tissue so we can mobilize it and get it back to where it belongs to provide that stability. This is what we use, okay? So this is a drill that's being introduced with a drill guide right here. We drill holes inside the socket, inside the glenoid here to put anchors in. And anchors have sutures that allow us to grab the labrum and bring it back to where it belongs. And this is pictures of exactly what we're getting at here. So if we're looking straight onto this socket right here, I'm looking in from the back with my camera. From the front, we come in from the front of the shoulder. We drill into here and place anchors, and these anchors have sutures that come out. We wrap around the labrum to rebuild over here real labral tissue. So this is the socket. This is the labral tissue that we pull back up, and these are the sutures that we use to fix the labral tissue back to the socket so the humeral head doesn't come out and dislocate anymore. These are the anchors that we use. They're all different kinds. Some of them are made of all suture, which is the ones that typically, for the most part, the ones that I use are all suture anchors, and they go right into the bone and they're just made of suture. And you can see here, we've already placed that anchor. So we drilled, we placed the anchor. Here's the sutures coming out. Now we got to go put it around all this tissue over here. This is the device, a passing device that we put in the shoulder. It wraps around the tissue and it comes out. And this is another suture shuttling device. And so this helps us capture that tissue to bring it back up and put it on the face of the glenoid. This is after we've done that a few times. I put a few anchors in there, and then here's a few of the sutures in place, really pulling that tissue back up so it provides a nice bumper or buffer for that humeral head not to go out and dislocate. This is another view as we come down. We're looking straight down. And if you remember before, this is the socket. And over here, it was nothing there before. It was all empty space. Now we've built back that labrum up on the socket, and hopefully it provides, well, not hopefully, but it will provide some resistance to that humeral head coming out. And then here's another view as well. Here's the socket right here. And instead of there being no tissue over here, we've really built this entire bumper of tissue back up on the side here to help keep that humeral head where it belongs. So that case there was shoulder instability from someone who has a shoulder dislocation, which is very common in sports. When I was covering the New York City Marathon, there was a gentleman that dislocated his shoulder. During the marathon, I had to reduce or relocate the shoulder in the finish line tent after the marathon. When I was covering a fencing event down in Charlotte, there was a fencer dislocated their shoulder, and I had to relocate the shoulder. And every time you dislocate the shoulder, you tear some of that soft tissue or that labrum that then needs to potentially be fixed later on. And that's how we do it. All right, moving on. As a 22-year-old basketball player, has what we call a bucket handle meniscus tear. So the meniscus is in the knee. This is going to be a knee case. And the meniscus is really a shock absorber and a cushion for the knee. But meniscus tears are very common in athletes, and these bucket handle ones are very complex types of tears. Procedure and plan here is to go in again with an arthroscopic, minimally invasive procedure to repair this meniscus. So now we're looking into the knee joint itself. We're looking straight in. We call this the notch right here. I know it's a little blurry, but we have a lot of fluid that we put through these joints. This is the ACL. If you can see my cursor, I hope here, this is the ACL, and this is normal. This right here is the flipped meniscus, the injured flipped meniscus that's flipped inside the joint, and it's resting right next to the ACL. This meniscus doesn't belong here. That's not the normal place for it. And so this is our problem, and this is what we need to fix. And this is why this basketball player was unable to compete. Their knee kept locking on them because they had this meniscus that was in the wrong place. And so again, meniscus right here, and I'll play a video, and you'll see I'm going to be probing this meniscus with my probe, my instrument. I'm pulling on it, and you can see how it just pulls, and it just does not belong in that location, which is called the notch. And you can see how loose it is. And when this patient and this athlete flexes and extends his knee, he has pain and clicking. Now that's the normal ACL my probe's on right there, just demonstrating that that ACL is normal and that ACL looks fine. We don't need to do anything with the ACL. Now we're clearing some of the fluid a little bit, and then here it is. Here's that flipped loose meniscus, again, that's stuck in the notch, and then that's a good ACL there. Now, if you look here, this top that we're looking at, this almost looks like that shoulder we're talking about before. This is your end of your femur in the knee. So if you know, like a chicken bone, right? If you have a chicken bone, the white on the end of the chicken bone, that's the cartilage. Well, this is your white on the end of your chicken bone. This is your end of your knee bone right here. This is your cartilage. Underneath here is the meniscus. This is the whole tear pattern right here. This big hole here, this meniscus is flipped over here, and this meniscus that was into the notch that we were pulling on, that belongs back over here. So you have to push the whole thing back in because it's been torn all the way around and flipped into the notch of the knee, into the middle of the knee. And so here, that big hole right there, that's where the meniscus belongs. And it got torn there and flipped. You can see this whole portion of the meniscus is flipped into the central portion of the knee where it doesn't belong, sitting right next to the ACL, causing, again, as I said, very severe symptoms where this patient could not play and really had difficulty walking. And you can see it's torn all there and has to go back to where it belongs over there. And so now I'm going to be coming in with a needle here and piercing this meniscus, because this was how we're going to fix it. We're going to put different needles in, and we're going to be shuttling sutures through here to fix this meniscus and put it back to where it belongs, so it's no longer loose and mobile and flapping into the joint. So there's a spinal needle that's going in there through the meniscus to do that. Here's another one that goes through the meniscus, and what have I done? I've taken the spinal needle and I put it through this suture lasso here and suture passer. And then this is the meniscus behind us right there. And then this is the femur, this is the bottom, this is the tibia, your shin bone right here. And then this is another way in which we're going to try to fix the meniscus. I passed a little passing suture in through here, and then I'm going to lasso it with this other lasso that I have here. So as you can see, orthopedic surgery is very hands-on, it's very technical. And you get to use your hands, and in this manner, we're operating through arthroscopic means. And then I lasso this suture, and I'm going to pull everything out, and you're going to see that's going to be wrapped around, or here's a video actually to show how it's done. So you have this loop. I'm coming in from outside through the meniscus, looping myself through that spinal needle. I'm now going to put we call it a PDS suture, but a suture that goes through the spinal needle and comes out there. And when you see the purple coming out, there it is. So there's the purple suture that comes out. Then I'm going to pull that spinal needle back, and that's that purple aspect of it is going to remain within my lasso, and then now I can pull back on my lasso, and I have a fixated meniscus to where it belongs. And you can see we're getting it out of the center part of the knee and putting it back to where it belongs for this patient. And I'm going to suture another, I'm going to shuttle another suture in through there for the final fixation. But you can see it pulls the meniscus back to where it belongs so it can heal on the capsule. So it's no longer flipping inside the knee and causing this patient these symptoms. And now you can see the final product, or nearly the final product, but my probe is probing. Here's the suture here holding the meniscus in. Here's another suture holding meniscus back. There's another suture over here holding the meniscus back to where it belongs. And then this will all heal in time, and the patient will have his preserved meniscus. We didn't have to cut this out. We don't want to cut it out. Now here's when we're done. We kind of took a step back. We look all the way around and see this meniscus is all nice, and it's been placed back to where it belongs over here. Whereas before, this used to be a hole and the meniscus was flipped right over here into the center of the knee. Now it's way back on the periphery, exactly where it belongs. It's no longer immobile. It's not going to cause the patient any problems. So that was a complex knee case with meniscus tear, and how we would address something like that. Very common in athletes. And some of the athletes listening on may have even had meniscus tear. So the next case is a professional basketball player, 23 years old. The patella tendon is the tendon that is just attaches your kneecap to your shin bone. And that many athletes have had patella tendonitis. If you've had that, you know what I'm talking about. That's your patella tendon. Well, this patient ruptured that. They tore that tendon playing basketball. They had a repair in the past, and now they tore it again. And so they came to me for a re-tear of a prior surgery. So if you can imagine, very devastating, especially for a young 23-year-old professional basketball player. So the plan is let's go fix it. We're going to plan to fix this when we're going to use an Achilles to augment this as well. And I'll show you what that means, okay? So getting in there, this is what we find. This is the patella right here. This is the kneecap that's been cut open here. This is the kneecap. Here is the quad tendon up here. This is the patella tendon down here. These sutures are all sutures that were placed by the prior surgeon, and they just, they exploded, they tore, and everything tore. And so I had to get rid of these sutures. We had to define where our patella tendon was. See, this is the kneecap, and we got to put this patella tendon back to the kneecap, back where it belongs. This is after I went and placed a bunch of sutures in the patella tendon right here. All those sutures, they're coming out here. Again, this is the shin bone down here. This is the thigh bone up here. And then these are the sutures that I placed in the patella tendon. We also drilled holes in the kneecap here, and I'll show you how we're going to shuttle. We're going to take these sutures, place them through this kneecap, and pull them out there to pull the patella tendon back up against the patella, again, where it belongs, recreating the normal anatomy again. And so here's a video showing that. I'll mute that there. So I'm shuttling these sutures through the patella, through the kneecap. We call it the patella. And this is going to bring that patella tendon up against the kneecap where it belongs. And again, this is the shin down here. This is the thigh up here. And we're shuttling those sutures through, as we had already drilled our tunnels with a drill through the kneecap. So you can see the sutures now being pulled through the kneecap. So I can pull the patella tendon back up into the patella, into the kneecap, and recreate that patella. And so unlike before, this is an open case. Whereas before you saw arthroscopic cases where you had a lot of fluid in the joint, obviously this is an open case. And then we have our sutures through the patella. And now we can pull the patella tendon back up to the kneecap, up to the patella where it actually belongs. And there is a picture of it right there. All these sutures are pulled up in through the patella, and we're going to pull that patella tendon back up. And now we've done that. We've tied the sutures over the top. You can see there's no more gap. There's no more space in between here. This is the patella tendon. This is the kneecap, and it's pulled right back up, and it's fixed appropriately. Now, this patient is the second time he was injured, right? So I want to augment this. I want to give him more support, more structure. So what do I use? We use an Achilles allograft. So it's an Achilles from a cadaver. This is the Achilles that's placed right over the top. This gives more support, more structure, more collagen to this construct to help him have a successful outcome. And so this is me placing that Achilles allograft right over the top here. There's a little video showing us. So there it is, placed right over the top. And now I'm going to suture that back over the top of the patella tendon and the patella, so it has more stability. So here you go. There's been sutures placed all the way around and all the way down. And then now this is the final construct with the Achilles allograft over the top of this to provide more stability for this basketball player. And now we put it through a range of motion in the operating room. Make sure there's no problems. And there's his new really recreated patella tendon now is attached to the patella. Now here are his x-rays. This is looking from the side. And why am I showing these? Well, this is the thigh bone, femur, right? This is the shin bone, tibia right here. That's the fibula back there. This is the kneecap called the patella. Prior to the surgery, this is his kneecap in relation to his tibia. See how high it is? It's way up here because the patella tendon, which belongs right here, was not intact. So this kneecap was high riding it. It got elevated. We call this patella alta. After the surgery, his kneecap's back where it belongs because his patella tendon, which is here, is holding the kneecap back down to where it belongs in the right position. Whereas before it wasn't. So the kneecap is floating up, further up. All right. So moving on, ACL. Everybody is very familiar with ACLs, right? You have ACL injuries and football players, soccer players. There's a lot of ACL injuries that happen. So I'm going to show you an ACL case and how we reconstruct and give a patient a new ACL. And you do that. In this case, I did it by taking the central third of the patella tendon and some bone from the patella itself and from the tibia, from the shin bone. And then we use that graft from the patient's own patella tendon to recreate it. Now, I know you just saw patella tendon reconstruction. We actually take this central portion, and then we suture back the two ends of the patella tendon, and then that regrows, and patients do just fine by taking their central third of their patella tendon for this. This is actually the gold standard way in which to do an ACL reconstruction. And so I'm not going to show us harvesting that graft. We'll just show the intra-articular inside the knee aspects. And so this is, my probe is on the meniscus. This is a normal meniscus right here. So again, if you remember our prior meniscus case, we then recreated this. We put our meniscus back to look like this, way back in the periphery. This is normal. This is the end of the chicken bone right here of the femur, distal end of the femur. This is the shin aspect of the shin, the tibia right here. And again, the meniscus, this is normal. We didn't have to do anything to this. This is me just probing the meniscus to show that it looks normal. It has a little bit of a cushion effect. You can see a little indentation right there. And then I'm pushing down on the cartilage. Oh, sorry, not the meniscus, the cartilage here, and then cartilage here on the tibia to show that indents. This is underneath the kneecap. This is the kneecap here. This is part of where the kneecap articulates, the part that is on the other side. And again, this is normal cartilage here. And then this is the ACL. It is completely torn. This is the ACL footprint on the tibia, on the shin bone right here. This is all the bulbous torn pieces of the ACL. It's completely torn. And again, you can see here, torn ACL right here. It belongs way up here and going through here. It's all torn right here. And this is the patient's problem. They have instability because of a torn ACL. And so we're going in to fix their ACL. And so in this position right here that you can see here, I then place I get rid of this old tissue, torn tissue. I place a pin, a drill pin right through here, and that comes up into the joint. Then we place another reamer, we call it, it goes over it, and that reamer creates a tunnel right here. And this tunnel in the shin is where we're going to pass our ACL graft up and into the knee. I then drill another drill pin across to the femur aspect on the other side. So this is our tibial tunnel, our shin bone tunnel. This is our femoral tunnel on the thigh bone. And then the graft is going to come up and go across here, and that's going to recreate our ACL. And then this is the tunnel that I drilled on the femur right here. So you use this as a guide, and then you drill over this to make it wider, to make a wider tunnel, as you see here. This is a suture that we put through to help us just pass the graft. And then here's us pulling the graft up. Remember I said it has a piece of bone that we took, and then attached to the bone is patella tendon. On the other end is another piece of bone. And so we take these sutures and we pull it up through, and we're going to pull it up through from the tibia all the way through the joint and into the femur. And we're going to dock it, this bone right in there. And then we're going to put a screw in there to fix it. So there's the ACL. There's the new ACL that's going right up through where it belongs and into its appropriate tunnel there. This is us getting ready to place the screw. And then there's the screw right there that is placed to fix this in the femur or the thigh bone. And then here's the ACL coming across the joint where it should have been, rather than just torn as you saw earlier. So that's an ACL reconstruction. So, I hope that this is interesting, to you. It's what we do from an orthopedic standpoint, but this is how we address and this is how we fix sports problems. And as I said, it is very hands-on as an orthopedic surgeon. Going into another problem that is very common. This is a sports hip issue. It's called FAI, which we call femoral acetabular impingement, but basically it's hip impingement. And so many athletes have this. They have groin pain. They have, and that's because that a certain part of their leg, of their proximal femur, the upper part of their thigh, because it comes into the hip joint, that part is coming up and it's impinging upon the labrum. And the labrum is similar to the shoulder. It is a ring of tissue that surrounds the socket. And once that gets impinged upon, that can be damaged, it can get torn, and that can also cause some cartilage damage. And in this patient, they've had non-operative management of physical therapy and such, and then they're at the point where a surgery is indicated. So once again, this is a minimally invasive surgery. We go in with an arthroscope, and we do it in a minimally invasive manner. Here's what I'm talking about by the impingement. Here's normal. You have the normal round femoral head. This is the top of the femur right here. This is the leg bone here, comes up into the femur. This is the ball and socket joint of the hip. And here's the ball of the femur. This is normal. It has a normal, like, rounded contour. This is a cam. You can see there's a bump here. And when you flex the leg, that bump comes up and it hits the labrum and it causes impingement of the labrum. And these are other types of impingement that can occur as well. And that can cause pain. Here's the surgery and how we position the patient during surgery. They put them on their back right here. I don't use a post. None of us really use a post anymore. So this is not there, but put the patient on the back, and these are the portals on the side, meaning the incisions that we make are going to be right on the side of the hip. We place these instruments, the camera and other long instruments inside the hip, and we put fluid into the hip as we did the other joint. And that allows us to work within the hip in a minimally invasive fashion through these various instruments, and we do it from the side of the patient, from the side of the hip like this. Now we're inside the hip. This, as similar to the shoulder, if you can remember, this is the ball here. That's the articular cartilage. This is the socket. And in this case, it's not called a glenoid, it's called an acetabulum, but that's the socket. This is the labrum of the acetabulum over there. And we'll see where we have to fix that. I'm making another portal, another entry access point over here with a guide wire that's coming through over here. Again, this is the head of the femur. This is the socket over here. This is a cannula, is what we call it. Basically, we're allowed, we put instruments through this. And so we put this in and we're allowed, we can pass instruments through. And then this is the labrum right here of the socket. Take a knife in here, we cut the capsule. So each joint, every joint's surrounded by a capsule of tissue. We have to cut that capsule. And you can see a video of me cutting the capsule here to give us access and give us more space. But here's that knife coming in. Here's the labrum right over here. So I'm taking care not to touch the labrum, not to injure the labrum as I cut through the capsule to give us more access to the joint itself. And I'm going to cut across the capsule towards us. And this is, again, the ball of the femur here. There's the socket over there. And here's the labrum up here. And I'm cutting right through the capsule over here to create some space so we can actually work and we can see what we need to see. Now there's no fluid in the joint right now. If it looks different from before, there's no fluid. This is dry. This is completely dry right now. And eventually I'm gonna pump some fluid in here. Then we're gonna see the fluid come in. But this is the labrum, as you can see more of the labrum up top here, up top of that socket and up top of the acetabulum there. Now I'm sticking my probe underneath the labrum. This is the socket, this is labrum. And there's a tear underneath there. And then there's another tear in this portion of the labrum right in through here. And so this labrum was unstable compared to the socket. So this is the labrum here, and this is the socket here, was unstable. And so this patient needed to be stabilized. Well, how do we do that? We prepare this part of the socket above the labrum. So labrum down here, above the labrum. This is called a burr. And then we burr the bone back because we want to create nice bony bleeding bed of bone. So when I place our anchors, similar as we did in the shoulder, we have good bone there, and that can actually heal the labrum too. So we prepare this with this burr, and I'll show you a video of me doing that. Behind me is the capsule, and I'm just burring this bony bed right here, and I'm creating a nice environment for me to place my anchors again that you saw how we did in the shoulder, how we placed the anchors. And then the sutures will come out of those anchors. We'll pass those sutures around the labrum, and then we'll tie them around the labrum, and we'll fix the labrum. And so this is me just shaving up and burring that bone to prepare it for our anchor placement. And then here is, again, as you saw in the shoulder, similar, here's the guide that's coming in. We're going to drill through this guide right next to the labrum. And then the sutures will come out of that anchor that we place. I've already now passed all the sutures around the labrum. Again, to orient, this is the socket down here. This is the labrum that surrounds the socket. And then here are the sutures that we passed around the labrum to stabilize the labrum. And now the probe is going to go through, and the probe is going to push down the labrum, showing that it's nice and stable and solid now. It's no longer loose. It's no longer going to cause this patient symptoms. And so pulling up, it's really nice and stable. It's well fixed now to the socket, lining the socket where it belongs. Now we're going to take the traction off. So basically we pulled down the leg and we had this separation. Now we're going to take that off, and you can see the head of the femur come down, and it's going to compress into the socket, compressing down, closing this space up here. And then you're going to see how the femoral head and the labrum are now in the appropriate position to where they need to be. And so this labrum now is in a good position. It's not going to be problematic for the patient because it's nice and well fixed with those sutures that we have there. There's another view of it here. You can see the labrum right here. It has the sutures around it here and here, and this labrum is well fixed. Now we go to the other aspect of this case, which is, I don't know if you remember when I said it before with hip impingement. With hip impingement, you have this bony bump. Well, this bony bump is right here, for example, and that bony bump needs to be shaved down. And so we say that this is convex in nature. We need to create a concavity right here. We need to shave that down and create a nice smooth surface so that when you flex the hip up, it doesn't go hit that labrum and cause damage to the labrum, as we just saw. And so here's coming in. This is that bump right here, and a little bit of that bump down here, and it's really flat. We need to create a concave, a concave surface. Here's me with my burr again here, doing that and creating that convex surface, that concave surface here. And then here's a little video of creating that concave surface in the on the femoral neck, it's called, next to the femoral head. But this is getting rid of that bump so it doesn't come up and it doesn't cause any more damage to the labrum. So we're just burring back some of that bone here, and creating this nice convex surface. And you can see these fragments. These are just bone fragments that are being filtered out with our water, and we have suction as well that's filtering those out. So I can see I just filtered it out there, so you can see a little bit better. And again, you're just burring down and getting rid of some of this cancellous calcified bone here, so this doesn't come up anymore and hit our labrum and cause damage to labrum, therefore causing pain to the patient. And so this is how that's done. And you can see now, after we've worked on it, you have this nice concave surface here, and no bony bump that's going to come up and engage and cause any more damage to that labrum anymore. So I think this is the last case that I have. So that was hip impingement, very common in sports, but there's not a lot of surgeons that treat that type of pathology, but I do. Here is a case of a hamstring tear, which we are all familiar with, and many athletes will have hamstring strains. You'll have a strain, a partial tear, most of which does not need surgery. However, sometimes the tears are so bad that multiple tendons have get torn off of the bone and they retract. They don't, they're many centimeters away from where they belong. And so this is that case where that happened to this patient. And I had to do an open repair of this hamstring. And so the idea is to go and make an incision. This is the back of the leg right here, is the back of the thigh. And you make an incision, you open it up. This is a nerve monitor that is helping us monitor the sciatic nerve, which is in that region. This is us here going at myself here mobilizing and finding that hamstring tendon to the back of the leg. This is the hamstring tendon that was detached from the bony attachment where it belongs up here in the top of the leg. This is the thigh down here, and the knee is way down at the bottom here, and the buttock is up in this region. And so this is the torn hamstring that has been pulled out of the posterior aspect of the back of the leg here. And then debriding away or cutting away scar tissue that is not helpful. It's not useful tissue, it's scar tissue. And we're trying to get back to healthy tendinous tissue. Now here's a video when we have mobilized and we have the hamstring that I want, and I'm ready to bring that hamstring back up to the bone and put it back on the bone. And I'm just demonstrating now how that hamstring, moves and with flexion and extension of the knee, as you would expect a hamstring to do. And we have that hamstring ready to put it back on bone. This is a picture of us, and I'm sorry it's not zoomed in more, of us putting, again, those anchors in with the sutures on, anchors into the bone through the hamstring, and then tying that hamstring back down onto the bone, putting it back where it belongs. And you can see here, all of these sutures coming out. These are sutures that are in anchors in the bone that we've placed with needles through the hamstring. And now all these sutures are coming out. We're going to tie all these sutures down, tying this hamstring, fixing it back to the bone. And we've done that here. And I'm just showing that, demonstrating that here. And then we're going to have a video showing the fixed hamstring to the bone. I'm flexing and extending the knee right now, and that hamstring is staying fixed right on the bone, right where it belongs. So it's no longer coming back and pulling back and forth because it's fixed where it belongs onto that bone. And so this is how you repair a hamstring that needs to be repaired in a patient that has a hamstring injury. So those are all the cases that I have for today. I hope to have brought you through the different path, the pursuit of an orthopedic sports medicine career, and then in addition to a little bit of an introduction as to what we do and how we treat and manage sports injuries as orthopedic surgeons. It's definitely hands-on, and as you can see, the entire path, though be it long and challenging, it is a very rewarding path. And then once you become an orthopedic sports medicine surgeon, you get to treat athletes and you get to help athletes either prevent injury, or once they unfortunately get injured, you can really go in and you can, and from a surgical standpoint, help them get back to sport. So again, Anthony, I just want to thank you and the SWAG initiative for inviting me to be a part of this. This is a great experience, and again, there's a reason why I jumped on this opportunity, is because of my background as a former scholar student athlete, and I know how important it is to sort of provide that guidance and that mentorship and introduction to this field. So if we have any questions.
Well, first, I just want to say thank you. That was an amazing display of technology and your skill set for various injuries. You know, sometimes we just hear about repair, we hear about surgery, but actually see all the details that go into it is very intricate. Like, I guess the 3 extra years of the fellowship paid off, and you got the experience that you needed. So I wanted to jump back towards and ask the first question. You started off saying that you played college football. Was
Yes,
it
sir.
difficult to manage like practice time and as well as study time and the ability to get those classes that you needed to put you on your way?
Yeah, that's always going to be a challenge, and that's a great question, Anthony. Because certainly as an athlete, and then when you play at the collegiate level, and then where I played was Division I, so there was year round, right? So we had we had fall ball, which is our season, and then we had winter workouts, an entire section of winter workouts after we came back from the winter break. I mean, and then we had spring ball, and so it was year round. And so it did become challenging, right? You need to be very focused, and you need to be disciplined. And it helps when you have coaches that are around to support you. It helps when you have teammates that are around to help you and help each other in that process. But certainly you have less total time to be studying than the average student, because you're at practice, you know, X amount of hours a day. Then you're lifting in the weight room, you're watching film. And so certainly to get the time in to study really takes a lot of discipline and a lot of commitment to do so. So that can be a challenge. But I know that Brown University, for example, and a lot of other places, they did work around schedules a bit as best they could to try to get that lab time in and try to get all those prerequisite courses in. But for me, as I said, I was an economics major. And so I had to study hard for my economics degree. But then when I came back to do all my prerequisites for medical school, I was at NYU, where I was not an athlete. So the only thing I was doing then was doing my recreational athletics and working out. And I was able to dedicate all my time to doing my pre-medical work. But yeah, as I said, especially at the Division I level, and if you're playing year-round sports, it does become a challenge. It's certainly doable. It's certainly doable with commitment and dedication and hard work and persistence. But you're right, that can be a challenging aspect. So you think you just got to work very closely with your professors, with your coaches, and your guidance counselors. And that's why having that vision and having that purpose is very important. If you identify where you want to be and how you know to get there.
So I will open up the floor to anybody else that has a question. Okay, I see Elijah, if you don't mind coming off of mute and asking your question.
Hi. During your time as a college athlete, did you find anything that you learned in the classroom to apply to like your time as an athlete or taking care of yourself or in your teammates?
That I learned in the classroom from a scientific perspective, or just generally speaking as a student that helped me on the field?
During like scientifically, what you learned?
Oh, so yeah, there's a lot that you learn as an undergraduate student, when you're going through things. But the courses that you're taking from a science perspective are biology, both human biology, and you're doing animal and plant biology as well. You're doing biochemistry, you're doing organic chemistry, and then you're in the lab. So you really sort of get into the human anatomy and that sort of science-based work when you get into medical school. And so I would say I probably would have utilized a lot more of that background from my medical school training, directly at that point in time. But, there's certainly things that we did learn, during that undergraduate, pre-medical scientific work that helped. But I would say during medical school, you're really getting into more of the human anatomy, human biology, and then clinical management of patients, which you don't really get exposure to. And actually, that leads me into something that I wanted to mention is that while you're in your undergrad, it is important to get out there and shadow. I think it is important to reach out and to create that mentorship and that network. So then you can kind of keep your eye on the prize. And as you're studying and doing these basic science courses, you're still out there in the clinical scenarios, in the office with maybe an orthopedic surgeon, a pediatrician, an internal medicine doctor, and you're seeing patients. And so you're sort of reminding yourself with all of this hard work and this schoolwork and this time spent in the library studying organic molecules for your organic chemistry class, why it's all worth it in the long run to sort of keep that vision appropriate and to keep your eye on the prize. So I think it is important to do that.
Thank you. Stephanie has a question.
I do. What a wonderful presentation. Thank you so much. I do have a question about mentoring and what happened for you when you were in high school that sparked your interest in science. Was it the teams and the sports, or was it a particular mentor, or was it someone that exposed it to you at the school level or in your family? Just interested to know how you got started in this, on the scientific journey.
Yeah, great question. So I'd have to say all of the above, Stephanie. So as an athlete, I obviously had my various injuries, surgical and non-surgical, but there was the surgical ones and the non-surgical ones that led me to orthopedic surgeons and also a non-operative non-operative sports medicine specialist that really were my introductions to the field. So I had injuries as a young student athlete when I was in high school, some of which required surgery, one of which required a hard back brace for 5 months. Because I had some stress fractures, in my back, and I missed one of my basketball seasons for that. I had 2 knee surgeries and various other injuries that I needed addressed. But at that time, the physicians I happened to go to, well, they were the Olympic docs for the U.S. Soccer team when Mia Hamm was with the team back then, and Brittany Chastain in that group. So they were, and they happened to be, I'm from Maine, so they happened to be the docs there. And so when I went to see them, I was obviously nervous, like any athlete is. Am I going to be able to play? If I can get back to play, am I going to be able to play at the same level? Am I going to be constantly hampered by this injury that I have? You don't know what it means. And so it was wonderful to have those docs, take care of me and say to me confidently, this is what we need to do, either from a non-surgical standpoint or a surgical standpoint. But if we do these things and you commit to this and you follow this path, we'll get you back. And that happened for me. And so each and every time I got back and I was able to finish my high school career, I went and played in college, obviously after that. And so those are really influential moments in my life. And I stayed in touch with those doctors. And so I called them when I was deciding to go back to NYU and do this. And I had conversations with them many years later, and they encouraged me to go into medicine. And then, of course, during that process, I had a family that was incredibly supportive to go down this path of medicine. They instilled that confidence in me, and they were really and have been ever since those early days my strongest support system. And I think that's important for all of us, because as I said before, and I think we lose that sometimes with athletes, is that we all need help. We all need support. We all need consistent support from our closest members of our family that are going to be there to do that, and then mentors that are on that path that we want to be on, that actually know how to take those next steps and that can help us take those next steps. And so for me, it was really all of the above.
Thank you.
So the next question I had is wanted to know, you spoke about the support from the school, you talked about the support from family. How would you give advice to some of the listeners that might hear this and say, well, I'm in a school that prioritizes practice over education? How do you tell them or give them guidance to how to structure it or speak on behalf of their pursuit to want to do medicine while still playing sports?
So I would first say and recognize that is a challenging scenario to be in. So there is not an easy solution to something like that, because I can appreciate that, looking back as a student athlete, you want to play, right? So the last thing you want to tell your coach many times is that, look, I have to study, I have to do this, I have to do that. You're nervous. You don't want to ask your coach to carve time out of practice and out of sports of fear of that you might not be included and you might not be able to play. So I think that's a tricky scenario. I think that's when family supports come in. I think that's when mentors can come in and be very helpful, adults that can help guide and manage that conversation. Also, I would say that as a young student athlete, which is why I think those that are involved with SWAG, why this initiative is so important, is that if you have that vision again of where you want to be at the end of the day. Now, yes, when I was playing, did I want to play in the pros? Of course I did. But while I was playing, I realized that I may not, right? Even though that was my goal, I may not play in the professional. So I wanted to have something that I could potentially do after sports. And this other organization that I'm on the board with, Athlete Soul, we constantly find that athletes have not prepared themselves for a life after sport because many of them didn't imagine a life after sport. They were just focused on that one sport, going pro, getting to the last level, and then figuring it out once they got there. And so I think it is important for that young student athlete to still recognize, where do I want to be at the end of all this? And what if an injury happens? Or what if I just get to the next level and I'm not good enough to play at that next level? And so if they have that vision, they can prepare themselves as best possible. But they need the mentorship. They need those adults in the room that are going to come up and going to come to bat for them as well. That might be a guidance counselor. That might be the athletic trainer. That might be the team physician for the high school that's there, and they can talk with them, shadow them, and build a relationship there and say, hey, I have all these different concerns. But I think within the school scenario, it might be more of the guidance counselors and the teachers that may help have those conversations.
Okay. And I have one last question that stuck out to me. You talked earlier about doing the 4 years at undergrad. And you said you had to go back to school for the, prerequisites for medical school. You had to take some classes. Could you give some of the students that might be listening advice on some of the key classes that they might need in undergrad to make sure that they're in course or in alignment with heading to medical school?
Yeah, great question. So you can go to undergraduate university and you can be a pre-medicine, a pre-medical major. And so you can major in pre-medical studies. And to fulfill that major, all of those courses will then fulfill your courses that you need for medical school. So that's one way of doing it. There's many people that go in and they'll be a history major, an economics major, something else. But while they're doing that, they'll make sure they're taking all the prerequisites that still allow them to be eligible to go to medical school. Once you get there to your undergraduate university, you don't have to declare right away typically. So you have a year or so to figure out, what you want to have as your major, your minor, stuff like that. And during that process, I would meet with your guidance counselor, and typically at that level, at the university level, you have someone that is dedicated to you and a selected number of other students to guide you in that process. And it's very well known. And I would ask, what are the prerequisites to go into medical school? And then I would look at each medical school, because each medical school, although there might be 95, 98% similar, there's a couple that might have one or two different courses that you need. And so it's typically going to be biology, chemistry, organic chemistry, biochemistry. So these are the courses. And they're going to require, some required, you have like a history or an English course, but for the most part, those are the scientific ones that they require. But the actual number of credits that are required, you certainly need to seek out that advice once you get to college with your guidance counselors there, and do your own research into those medical schools that you might be applying to see if they might have one or two courses outside of that normal 98% that every one of them will need as the prerequisite. And you can certainly do it if you don't major in it. You can certainly go major in history and just make sure as while you're doing your history major, you still do those other pre-medical prerequisite courses to put you in a position to take the MCAT and go to medical school.
Okay, thank you very much. If anyone else has any questions, please raise your hand or come off mute. If not, then we have been on for a duration of a little over an hour. So thank you for your time. Thank you for your presentation. We greatly appreciate your participation for this program. And if you have any parting words, we'll close it on that.
No, I just want to say this was a great pleasure of mine. Anytime I get to speak to young student athletes is always a pleasure. And I would say, for all of you that are on this talk, if you're in New York City, reach out to me. If you want to come into the office and shadow, if you want to come to the operating room, if you just want to gain exposure and experience and just see how things are run, see if it might be right for you or not. I can do it through me. We can introduce you to other surgeons that have those opportunities. If you're in other cities, please reach out to someone in your area, because I think that shadowing and doing those things are just so valuable. But for all the swag initiatives, the Mount Sinai related folks, please reach out and we can definitely get you in the right place. I have medical students that are coming through constantly. I had 2 here today that were working with me in the office, seeing patients. And again, trying to figure out, is this something for me, moving forward in the future, and kind of keeping their eye on the prize as they go through their various aspects of the training, that, oh, this is what I want to be when it's all said and done, which I think is very important. So reach out often, and then reach out to me if you need to, because that mentorship is vital. It's critical. It's important.
Thank you so much. And with that being said, this is another great edition of the Human and Sports Performance Series. I'm your host, Anthony Smalls. Everyone have a great night.